Hi folks, welcome to my YouTube channel. So today we will discuss about the renal cell oncocytoma. So starting from the definition, these are the benign tumors which commonly arises from the renal epithelium neoplasm, specifically from the intercalated cells, which are characterized by the large round eosinophilic cells which are pegged with the mitochondria. We will go over the definition much more when we will discuss about the histology. This tumor commonly arises from the renal cortex and comprises 5 to 9% of the total renal cell tumors. And they predominantly involve the male much more compared to the females. And they have the broader age range, but their mean age is around 60s. And there's a one condition which is called as the renal oncocytosis, in which kidney develop multiple oncocytic lesions or oncocytomas or chromophobe tumors are the hybrid both tumors at the same time. So these conditions are known as are associated with the Britt-Hug-Dubé syndrome. Discussing about the pathophysiology of these tumor arises from the renal intercalated cells which are pegged with the respiratory defective mitochondria. So initially what happened when there is a mutation in the mitochondria, it will activate the metabolic checkpoint which will lead to autophagy impairment. So there is no apoptosis process. So the defective mitochondria will accumulate. Because of accumulation of these defective mitochondria, so the cytoplasm will depicts or have the granular and the eosinophilic or the pinkish type of the cytoplasm in the tumor cells. There are multiple molecular variants which can give rise to the oncocytomas, but majority there are two most significant. So the first is when there's a rearrangement of the CCND1 gene, which is located at the 11 chromosome on his short arm, or the second variant includes when there is an aneuploidy in the chromosome Y and the chromosome 1. So the importance of aneuploidy of chromosome Y and the 1 is that if the oncocytoma arises because of these aneuploidies, and if there is an additional p53 mutation, the oncocytomas will progress to the eosinophilic chromophobe renal cell carcinoma. So it is very important to differentiate between these two entities, and the most pitfall in these conditions is that these both tumors can look similar in terms of morphology because they both have the high amount of a cytoplasm. So we have to do the immunohistochemistry to differentiate these two different entities. Talking about the clinical features, as we discussed earlier, that these are the benign tumors, mostly asymptomatic. They can be detected incidentally on the imaging, which was done because of some unrelated reasons, and sometimes they can present with the hematuria, okay, they can present with the dysuria, and if they grow bigger in the size, they can present with the mass as well. While in terms of the gross description, these tumors are very well circumscribed. They commonly arises in the cortex region, and the tumor can grow outward into the perinephric fat and inward toward the sinus fat, or even they can compress the renal vein as well. They commonly expand, but they do not invade the perinephric fat or the sinus fat. And when we cut and when we open them, there is commonly a central stellate type of the scar, and there can be some hemorrhagic areas as well, but there is no necrosis. So as we said, mostly these tumors are the benign variety. So this is one of the gross picture of this renal oncocytics type of the tumors. So here we can see that the tumor is well circumscribed. It is present in the cortex region of the kidney, and it has the tan brown to mahogany type of the color. And commonly these tumors have the central stellate scar. They can have the some hemorrhagic areas, but no necrosis is present in these tumor most of the time. And when they can grow outward and they can involve the perinephric fat, they can grow inward, they can involve the sinus fat, sinus other structures present in the sinus vein, especially they can compress the renal vein as well. But there is no necrosis in these type of the tumors. Discussing about the microscopic features, these are the well circumscribed lesions. They have the variable type of the architecture, but typically they have the small solid nest. And the other architecture includes like tubular, micro, and macrocystic. And these tumors, but all of these architectures, they have the pegged nets of the mitochondria. Because of that, they have the high amount of pinkish or the eosinophilic cytoplasm. So this is one of the low power picture of these renal cell oncocytomas. So the first, the stroma is most of the time in these tumor is unique, and it is very edematous type. And here we can see that there is like a variable amount of nested type of the tumor is present. And if we go on the high power, here we can see that the tumor cells in they contain the abundant amount of the pinkish or the eosinophilic cytoplasm, and they have a very uniform rounded nuclei. And most of the nuclei, they have the prominent nucleoli as well. But there is hardly any mitosis, and there is hardly any amount of the necrosis present in these tumors. And these tumors are positive for the CD117 or the KIT, and it is a cell membrane immunohistochemical stain, which is commonly positive in the renal cell oncocytomas. And another stain is the CK7, which is mostly it is scattered or partially positive in the renal cell oncocytomas, or it can be dead negative as well. But if we have to differentiate it from the eosinophilic variant of the chromophobe tumor, CK7 is fully positive. So this immunohistochemistry can help us to differentiate these two variants, because most of the time morphologically they look very similar. So this is the end of my presentation.